Thank you,
apologize.
and I will be try to be as short as possible. So I'll be talking about how it shows lenticular pathologies, and I'll be talking about morphology in particular. Since it's a swept source OCT, it scans deeper and it scans wider, and one is able to see the posterior capsule. And which is how it helps in seeing the posterior capsule, it helps in seeing the lens contour and the lens and the IOL tilt. In white cataracts, it's especially useful because depending on the morphology, if I see a cataract which is solid with no fluid, I'm happy to go ahead with a single stage capsulorhexis. If I see a cataract which has fluid anteriorly, I would like to go for needle aspiration without a prior, which will decrease the risk of a runaway capsule. On the other hand, if I see swollen fibers anteriorly and lens fluid cavities posteriorly, in that case, I would like to go ahead with a forceps-assisted two-stage CCC or a femtocapsulorhexis. It's very useful in posterior polar cataracts, one, to see the morphology and to see the involvement of the posterior polar cataract. And in brief, it's been shown that it has a 100% sensitivity and 100% negative predictive value. If a PC rent is there in a posterior polar cataract, it will show up, and if it's not there, then also it will show up. In traumatic cataracts, again, the same thing, because the posterior capsule can be imaged. This is a case of an iatrogenic trauma. This was a patient receiving intravitreal steroids presented with a cataract. And you see the breach in the posterior capsule so beautifully, and you can plan your surgical plan accordingly. Detecting changes in lens contours, subtle lenticonus may sometimes be missed. This is a patient detected to have anterior lenticonus. Once you see this on ASOCT, and then you can go ahead, and this patient was later on detected to have Alport syndrome, and sometimes, this can be life-changing for the patient. White reflex in the pupillary area in a patient having undergone cataract surgery. And I'm not saying this is the American Academy saying this, that this has been mistaken for a posterior capsular opacification, IOL glistenings, capsular bag distension, and vitreous hemorrhage or haze. So you look carefully. If only the anterior and posterior surface is opacified, it's an IOL opacification. If it's within the lens, it's IOL glistenings. If it's behind the lens fluid, it's capsular bag distension syndrome, and the management of each of these is different, right? And the last is the evaluation of the IOL tilt. This was a patient aphakic implanted with a CMT flex for aphakia. Vision, however, improved only to 636, and there was pigment dispersion on the IOL. And one can see how beautifully this is showing the tilt of the IOL, and which is rubbing on the iris and showing the posterior, which is why the pigment dispersion was occurring. To summarize, I'll just finish here. The CASIA has the IOL cataract surgery. Frankly, Dr. Rushad has spoken about it. We've not been using it for that purpose. It doesn't yet measure axial length, so it's not a complete biometer in that sense, and we haven't been looking at it from the point of view of managing the power in cataract surgery patients.